Thank you, respected chairpersons. At the outset, let me thank Dr. Manikandan and Dr. Kiran for giving me this opportunity. And I should acknowledge the guidance and the contributions by Dr. Varun, who is our professor in radiology, who has generously given his images and videos for me, to me for these presentations. So straight away to the topic, the role of cardiac MRI in ischemic heart disease and other cardiomyopathies. An ideal imaging modality should have a good anatomical delineation. We should be able to assess the functional function of that organ and also the tissue characterization. As a cardiologist, the most easily available and most commonly used imaging modality is echocardiogram. But we know that there are few limitations for echocardiogram because of the echo has got 4 windows only because of the lung and the chest wall and its particular position. And since the alignment of the heart and the windows, if they are not perpendicular, most of the short axis views may have oblique cuts and the measurements can be different. RV and LV apex and anterolateral areas are difficult zones for an echocardiographer to obtain good images. So, and the tissue characterization is usually not much possible with ultrasound. So, then came the MRI. The basic principle of MRI is the usage of the hydrogen ions or the protons in the body. As we know, all the tissue contains these hydrogen ions according to the concentration of the water. So these hydrogen ions are actually a small protons which has got a spin. So they are small magnets. When they are aligned in a strong magnetic field, it will align to the major axis of the magnetic field. Once it is aligned, we give a RF energy and destabilize these ions. So it will have a different spin and alignment. And then we stop the RF energy. They will return back to the aligned precision by emitting energy. So based on this emitted energy that has been detected by the coil, we can get various gradations of the protons according to the tissue water content of different organs. So that is the basic principle. And because of this technology, we have got a very high signal to noise ratio, makes the images very clear with contrast, and also the moving spins to the relatively static tissue can be contrasted. So without giving dye, we can assess the blood volume and the shunt lesions. Then after obtaining different sequences by T1 and T2 weighted, which we will discuss in the few minutes, we can differentiate the different tissues, characterization of fat, fibrosis, edema, and iron. So this makes MRI an ideal imaging modality. So this is the basic protocol of the cardiac MRI. Usually we take first the scout or the still images, then go for the cine. Then we take T1 and T2 weighted images, then T1 and T2 mapping. Then we give the contrast to see for the first perfusion, first pass perfusion or the early gadolinium enhancement. Then wait for 10 to 15 minutes, take the late gadolinium enhancement, and then post-contrast T1, because the native T1 and post-contrast T1 images can be reanalyzed, and we can detect extra cellular volume also from that image. So this is the basic protocol of cardiac MRI that is being used. So the scout images we take in 3 planes, basically the axial 3 plane or our 3-chamber view, then the coronal and the sagittal views, and then the cine images again in these 3 images, and also the short axis images. A few words about the T1 and T2 weighted images. T1 is basically by giving a short repetition frequency and short acquisition time, the spin to lattice relaxation time, it will enhances the fat, and that will make an image where the myocardium will look very black and the blood as a bright image. So that is basically the T1 image. And T2 will looks like more like a echocardiogram image, where the tissue will have a minimal gray image and the blood will be black. So this is how to differentiate from a MRI picture. Now, once we give gadolinium, we can see the image on the left-hand side of this. This is the short axis view. You can see the right ventricle is getting filled with the gadolinium contrast. As the time passes or the beats moves, the RV get more filled, and then it goes to the LV in the third image. And in the last image at the right-hand corner and the upper part, you can see the both RV and LV is filled. And further beat, once from the LV, the contrast gets into the coronary, it will fill the myocardium, and you can see the arrow that has been given in the lower images. That shows that there is an area where contrast has not been reached. That shows this is a coronary occlusion or acute coronary syndrome. So perfusion defect in the early gadolinium enhancement is a feature of coronary occlusions or the coronary syndromes. Once we wait for 10 to 15 minutes, usually this gadolinium, if there is perfusion, is adequate and the tissues are of normal tissue, it will clear. If it is not, if there is fat, fibrosis or any other infiltrating tissues, the gadolinium will be present there at the late imaging. That is what is called as the LGE, late gadolinium enhancement. It will have different patterns according to the different pathology. So T1 weighted gradient echo has been used and the image is obtained at 10 to 20 minutes of interval. It can differentiate if it is obeying that LGE is obeying the coronary territory, and if you have got a transmural or a subendocardial, it may be most probably due to the ischemic involvement of the myocardium. If it is more in the insertion points of the RV in the short axis view, it can be due to mainly seen in HCM, and also in myocarditis you can have mid myocardial enhancement, and sarcoidosis you can have subepicardial enhancement. So based on these patterns you can differentiate what is the pathology. So that is the use of LGE in the cardiac MRI. So this is the image where you can see there is a subendocardial enhancement and then so a transmural enhancement in the nearby image. So that is usually a ischemic. Here you can see there is LG in the insertion points of the RV in the septum, and also sometimes in the mid myocardial wall. It is usually seen in the hypertrophic cardiomyopathy or in myocarditis, and in the last row, basically the subepicardial enhancement, that is more suggestive of a sarcoidosis. If I can get a pointer, that will be useful. So these are the basic sequences and its utilities. By cine, without contrast, we can assess the systolic function, ventricular volume, and the wall morphology. T1 weighted will differentiate or enhances the fibrosis and the fat. T2 will enhance the edema, and T2 star imaging, it is just an extension of T2 after by which we can assess whether there is iron deposition or not, and early gadolinium enhancement for a perfusion, and late gadolinium enhancement pattern of fibrosis, whether it is replacement fibrosis or the interstitial fibrosis. And extracellular volume, normally it is 25%. If there is exceeding extracellular volume, that is also suggestive of fibrosis or edematous infiltration of that tissue. So usually a patient comes with LV dysfunction without angina. We don't know whether it is ischemic cardiomyopathy or any late stages of myocarditis or any other infiltrative cardiomyopathy. MRI role is useful. As I have already said, the pattern of LG will be useful to differentiate between the different etiologies. We can clearly assess the ejection fraction because of the clarity of the contrast between the tissues and the blood. We can detect the scar. If there are large amount of scar, LG more than 15%, or if the scar is from opposite walls, the pro-arrhythmic potentials of that scars will be high. So we can give option of primary prevention of the sudden cardiac death, and cardiac sarcoidosis by its subepicardial involvement is a usually treatable disease with steroids and other immunomodulatory agents by which we can prevent further LV dysfunction. So for all these cardiac MRI is a useful tool. So this is basically the image of ischemic cardiomyopathy patient. We can see in the first blue arrow image, there is only 25% of subendocardial enhancement, while in the second image with the yellow arrow, there is more than 50%. So if there is more than 50% of LGE, that area is actually will contribute to the contractile function even if you revascularize it. So it is basically a sign of viability. So cardiac MRI has been used for viability. The features of viable tissues are LV end diastolic wall thickness more than 5.5. If LV wall hyperenhancement, which I have already shown in that image, if the cardiac MRI image, if the transmural involvement is less than 50%, it will be viable. The wall thickness after giving low dose dopamine, if it increases by 2 millimeter, that is also a sign of viability. So this is another image of LV dysfunction where the cardiac MRI can pick both edema and injury. If there is both edema and injury, it will go in favor of myocarditis. And for myocarditis now the guidelines, there is no need for tissue diagnosis now or tissue biopsy diagnosis. Cardiac MRI can clear-cut give the evidence of myocarditis by the image properties. So this is where there is severe LV dysfunction, and on the right hand side that is a T2 weighted image which shows increased enhancement in the T2 weighted images, that is suggestive of edema, and in T1 weighted images in the lower right button you can see mid myocardial enhancement, that is suggestive of there is edema and injury, which is a sign of myocarditis. Other is the patients with cardiac hypertrophy, patients, whether it is to differentiate between athlete's heart of the young individual or HCM, hypertensive heart disease versus HCM, and if a diagnosed HCM, whether these patients need any primary prevention, these cardiac MRI features will be useful. If the thickness is more than 28 to 30 millimeter, apical aneurysm, EF less than 50, and the LGE more than 15% of the LV wall, that is a feature suggestive of having sudden cardiac death. So these patients may be benefited from ICD. And also pre-procedure evaluation for suitable area for myectomy or alcohol ablation in patients with HCM. So this is a hypertrophic cardiomyopathy image. You can see the large, huge septum with systolic anterior motion. If you look in the image, we can see the negative shadow of the mitral valve going closer to the septum, that suggests of left ventricular outflow obstruction due to SAM. And in the right hand image, we can see the LG enhancements in the insertion points. So a high risk hypertrophic cardiomyopathy patient needs further evaluation, further treatment like surgical myectomy and ICD implantation. This is another image of hypertrophic cardiomyopathy where the hypertrophy is more into the apical region, and also the images are showing enhancements in the septum and also the lateral wall. Now there are some phenotypes by which we can even say that there is genetic mutation, especially when the crypts are seen in the infralateral region, and if there is elongated mitral valve, most of these patients will have genetic abnormalities. So their family also, they may be a transmissible hypertrophic cardiomyopathy. So this we have already discussed. Now regarding to differentiate between the cardiac masses, we can differentiate between clot and tumor, and also among the tumor between benign and the malignant tumor based on T1, T2 and the contrast enhancement. So this is an image where you can see a filling defect like thing in the right atrium and also in the RV, which was not enhancing. It was actually a clot that was seen in RV and even popping back to the right atrium during the tricuspid regurgitation. This is another mass you can see that is moving between the left atrium and the left ventricle. It is not that hypoindense. It is isoindense in the T1 images on the right hand side, so it was more of a myxoma. So we can differentiate between tumor and the clot and the tumors. This is another image, T2 weighted image. You can see a shadow of hyper enhancement in the septum, which was when done with fat suppression, that image become hypointense. So using fat suppression methodologies in cardiac MRI, you can differentiate lipoma from other tumors. Now regarding word about restrictive cardiomyopathy, thick hearts with heart failure, it can are the features of restrictive cardiomyopathy. This was a case of infiltration by the histiocytes, Eden-Chester disease. You can see a thick tissues in the right coronary region, left circumflex region, and the interatrial septum. So that is a feature of tumor infiltration. There was global enhancement. I will take only 20 more seconds. Global enhancement suggestive of amyloidosis, and iron quantification is also will be useful to differentiate between the iron overload cardiomyopathy. Previously we consider iron overload cardiomyopathy as a restrictive, but it can present as a dilated cardiomyopathy also. So in all cardiac MRI sequences, they do T2 star imaging, which leads to, by which we can detect the iron overload myopathy. It is also useful in pericardial disease. You can see the septal fluttering or the septal flash of the constrictive pericarditis, the thick and fibrinous pericardium. This was an early phase of tuberculous pericarditis. Patient responded to ATT and steroids even without pericardectomy. So to conclude, cardiac MRI is a non-invasive, non-ionizing imaging technique with high spatial resolution that is considered to be the gold standard for morphological assessment as well as the assessment of right and left ventricular systolic function and to differentiate the types of masses. Thank you.
It was a well-done talk covering all the aspects of MRI, cardiac MRI, for the functions and the anatomy. So now it is open for discussion.
Any special preparation needed for the patient when we are sending for a cardiac MRI?
Usually, what I know is that the heart rate should be relatively regular. So if there is a atrial fibrillation, multiple ectopics, sometimes the gated images may not be taken. That is one. Maybe 4 hours fasting is sufficient. There should not be contraindications like implantable devices, or if there is implantable devices, change it into the MRI mode. Cochlear implant and the aneurysm coils are considered as contraindications. There is no other, and creatinine values should be normal to give, ideally to give gadolinium, even though it is not that nephrotoxic. Even if there is renal failure, we can do the other images because of this extended T1 mapping and T2 mapping. Even without contrast, we can get tissue characterization. So there are some difficulties, but in majority of the patients, this cardiac MRIs can be done.
Whether a stress perfusion MRI or a SPECT is good for in triple vessel disease.
Okay. Regarding the viability, for the viability, we used to do the rest perfusion. In rest perfusion, they usually detect the cells which are alive, but cells may be interspaced and the fibrosis may be interspaced between the cells. So what they say is that the contractility after revascularization, even though there are viable cells, if the viable cells are not in a group, it will not act in contraction. So if there is a very large transmural infarction, which is more easily detectable by cardiac MRI, the MRI viability assessment gives a better predictor whether the left ventricular function will improve after revascularization. So these are the differences. Yes, especially in hypertrophic cardiomyopathy patients, if there is an event, then it becomes a secondary prevention. If there is not an event, the correct thickness assessment, sometimes by echocardiogram, the apical region, anterolateral region may not be that accessible by the echo imaging. Then the scar quantification, that is beautifully seen in cardiac MRI, especially in LG, the number of scars, the extent of scar, if the scar is very high, maybe chances of arrhythmias are high, even though it is a class 2B indication, but LV wall thickness more than 28-30 millimeter is a class 2A indication. So I feel that definitely helps.
For assessing viability, you have nuclear SPECT as well as MRI. So which one do you prefer?
That is the studies that shows that if we are doing viability by nuclear SPECT, it will detect only the number of viable cells. That cells may be at two different points, maybe at some at the endocardium, others at the epicardium, but then whether the extent of infarct and the rest of the viable tissue, to detect that, basically cardiac MRI may be useful. So the studies comparing SPECT to cardiac MRI viability, what they found was that cardiac MRI viability will give you more prediction whether the LV function will improve or not. So even the gold standard, if the more gold standard is PET, that will give more viable cells that are, but whether that will contribute to contraction once the revascularization is done, that information is better get by cardiac MRI.
I was actually hearing one of the lectures by one of the pioneers in India. So they were saying that post-MI in most of the metropolitan centers, it's become a standard routine practice. It's again not it going by data. Nowadays they say that if you're able to see a lot of myocardial edema and then document ferritin high ferritin levels, these are the patients who don't do well. And I believe these patients have an inflammatory component. The therapy of an anti-inflammatory treatment in acute post-myocardial infarction is gaining some importance. Do you think MRI will become a routine tool in post-MI in the days to come?
I'm not aware of that. Every post-MI patient, whether to get cardiac MRI, we don't have that practice. I don't know I don't know exactly.
More so in LV dysfunction.
In LV dysfunction patients, yes, in LV dysfunction patients, to assess the extent of the scar, sometimes even iron load overload cardiomyopathy can present as LV dysfunction. During acute MI, sometimes some patients with ST elevation, but normal coronaries, it may be a feature of myocarditis rather than this minocha. So to differentiate between minocha and myocarditis, basically the cardiac MRI may be also be useful.